Jill Rockbeisel, the chair of the department, and I'd like to welcome everyone to our Grand Rounds. I want to welcome our faculty, staff, trainees, as well as outside visitors. I also want to welcome Dean Reese, who's joining us for this presentation as well. So thank you, Dean. So I would like to have Dr. Chris Moreno, our organizer of Grand Rounds, do the introduction today, since he knows our guest speaker very well. Chris, you want to take it over?
Well, thank you very much, Dr. Rockbeisel, and welcome everyone. Not to put pressure on Esther, but you've generated a lot of outside interest here, so I know she's going to do a bang-up job. Dr. Esther O is an associate professor in the Division of Geriatric Medicine and Gerontology in the Department of Medicine at Johns Hopkins. She also holds appointments in the Department of Psychiatry and Behavioral Sciences, the Division of Neuropathology, and also at the Hopkins University School of Nursing. She is the co-director of the Johns Hopkins Memory and Alzheimer's Treatment Center, which is a multidisciplinary clinic with psychiatrists, geriatricians, and neurologists all working together. Dr. O's overarching clinical and research interests are in the field of Alzheimer's disease. Her interests include development of the biomarkers for early detection of Alzheimer's, including using artificial intelligence and machine learning methods, delirium and cognitive changes after surgery, including the use of Alzheimer's biomarkers to predict postoperative delirium. Her interests also include long-term cognitive changes associated with COVID-19 and sensory changes associated with Alzheimer's, such as hearing loss. Dr. O is currently the president-elect of the American Delirium Society and past chair of the Pre-Operative Cognition and Delirium Professional Interest Area of the Alzheimer's Association. I just want to say on a personal note, I've had the privilege of calling Esther a colleague and friend for the last 12 years, and work with her very closely in the Memory and Alzheimer's Treatment Center at Bayview as we're kind of getting things off the ground. And what I can say about Esther is, you know, she is a wonderful and caring clinician. And as a researcher, she really asks very insightful questions and kind of looking at particularly how can we help identify folks who are really at risk to develop this, you know, symptoms of this devastating illness. And it's also a very dedicated educator. And having said all that, welcome, Dr. O, and we look forward to your presentation.
Great. Thank you so much, Chris. And we miss you very much here as well. Thank you, everybody. Today, I would love to share with you some of the really a lot of work that my colleagues and I have done in the field of delirium, and just I think this is hopefully by the end of it, I can convince you that addressing delirium is actually one of the ways that we can address really one of the really important clinical questions, which is how to prevent dementia. So just by way of note, I've been actually one of my aspirations as a medical student was actually perhaps, you know, becoming a psychiatrist. I ended up choosing internal medicine and geriatrics, but I do have an appointment in psychiatry at Hopkins as well. So I want to start off with a patient story. So this was an article that was published in the Wall Street Journal, February of 2020. It says here, the surgical complication that can damage your brain. And it was a story about Bill and Sue Borton. And Mrs. Borton passed away from Alzheimer's disease, complications of Alzheimer's disease in, I believe, September of 2019. And so her story went like this. Bill Borton had no idea his wife's colorectal surgery could affect her mind. But a day later, Judy Borton couldn't remember her birthday or who the president was. She was experiencing symptoms of delirium, a confused state that is common in elderly patients after surgery or during intensive care stays. The delirium went away after a few days, but Mrs. Borton's cognitive abilities, which were already impaired, declined rapidly afterwards, says her husband, who is 84 and lives in Bethesda, Maryland. She was diagnosed with Alzheimer's disease a year later and died at age of 81 from complications of the disease in September. Her doctor suspects delirium contributed to Mrs. Borton's cognitive decline. I was Mrs. Borton's doctor at the memory clinic. She came to me having had a long, several years of history of mild cognitive impairment, underwent colorectal surgery and had a significant change in her cognitive trajectory. And her husband brought her to our clinic. We did an amyloid PET scan, confirmed that her underlying etiology of her dementia was most likely to be Alzheimer's disease, but she never quite recovered from that incident and eventually passed away. So this is an audience that's very well versed in delirium, so acute disorder of attention and cognition. But of course, it results in loss of independence, increased rate of medical complications, higher mortality, institutionalization coming in from home and ending up in nursing homes, and incident or new occurrence of dementia. 5 older persons develop delirium every minute. About 2.6 million older adults 65 and over develop delirium in the United States, costing about $164 billion in US annual healthcare expenditure. Now, all of us can recognize delirium, and it's usually the hyperactive delirium that we're alerted, especially when we're in the inpatient service. So, basically increased motor activity, loss of control of activity, restlessness, wandering, usually, phone call from the staff saying, doctor, you have to do something. The patient's pulling out the IV, pulled out the Foley already, and, can you do something? And you find the patient to be very confused. But I just want to emphasize that is just a very small proportion of patients who have delirium. Actually, that's only about 25% or 1/4. 75% or 3/4 is actually hypoactive delirium. So I like to call it the quiet delirium. So decreased activity, they're often very drowsy, inactive. They're usually really, not noticed. And nurses love them, doctors love them. We make rounds in the morning. We ask a lot of questions. The patient just kind of nods, has like a blanket over to her chin, and we step out and say, we really love Mrs. Smith. She's such a nice patient. She never complains. The nurses love her because she never rings the nurse's bell, and all the, but in fact, she doesn't even know what her name is. She's utterly confused. So that's the hypoactive delirium that unless we do active delirium screening, we tend to miss. And they're just as well associated with all the bad outcomes associated with hyperactive delirium, and most likely because they go unnoticed and perhaps undertreated. So today I'm here to really discuss with you about the bidirectionality of the association between delirium and dementia. We're a fairly young field, so we know a lot about epidemiology of delirium and its consequences. We understand the risk factors from epidemiological studies. Not so much about genetics, although there's a couple investigators at Harvard who are really active in this field, and very little about molecular mechanisms, although I want to tell you a little bit more about what might be happening when patients are having delirium symptoms by studies using biomarkers and some neuroimaging studies as well. But it's really a young field. The first, I would like to present a delirium epidemiological study, so where they determined that it might be a risk factor for incident or new occurrence of dementia. So this was a Vanta 85 plus study in Finland, where actually they recruited patients who were 85 years and over, and there were over 500 of them, and prospectively examined for dementia and cognitive decline. And they had different waves, so 3rd, 5th, 8th, and 10th year. And what they found was that about 40% had dementia at baseline, but they really wanted to see from looking at hospital records, if you experience delirium during hospitalization, does that increase the risk of new occurrence of dementia? And is delirium associated with accelerated cognitive decline? So what they found was that, yes, indeed, basically, if you experience delirium during hospitalization, so this is all based on chart review and probably some diagnostic codes, that you're at a really high risk of having dementia. So at baseline, they would have been cognitively normal. And at the follow-up waves, they determined that they have dementia clinically. And basically, if you had experienced a delirium, adjusted for a lot of other confounders, you're at higher risk. And it also actually was associated with, if you had underlying dementia, much greater or faster rate of decline. Now, what we wanted to do was more of a prospective study. So this is a paper that was published by the Harvard group. This is really elective or surgical population. And this was a cardiac surgery population. So CABG or valve replacement surgery. And it was published in New England Journal of Medicine 2021, over 200 individuals, 60 years and old and over. Basically, they checked the daily mental state exam and delirium assessments during hospitalization, and then 1, 6, and 12 months. They also did fairly in-depth neuropsychological testing at baseline because these were elective patient population. And what they found was that, as you can expect in cardiac population, they had a fairly high rate of delirium incidence, or up to 46%. So this is what they found was that, so at baseline, so this is an unmatched analysis, and you can already tell that people who had delirium during hospitalization, represented by this gray line, did have lower MMSE to start with. But what's really striking is that it's not so surprising that your cognitive scores will go down if you experience delirium compared to those who did not. But what was surprising was that actually some of them did actually go back to baseline, but the recovery was much, much slower. And patients with that delirium returned to baseline by about one month time period. But patients with delirium did not return to baseline at 1 year, many of them. And by delirium duration, if you had delirium that was longer than 3 days, at least in the study, they had even worse outcome. So it wasn't just that they had delirium, but then delirium duration, and hopefully I can demonstrate to you that delirium severity may actually be more important factors of predictions in terms of your outcomes, rather than just having whether they had delirium or not. And so the implications is that cognitive recovery is slower in those with postoperative delirium. And that has, of course, has implications in rehab and readmissions as well. If you discharge a patient who had delirium at the time of discharge, they're more likely to come back within 30 days. And you have a certain set number of Medicare days that are allowable under Medicare rules for physical therapy, occupational therapy, and SLPs. And so if you don't make the progress that you need to, at the end of the month, you kind of need to decide, well, can you go back home by yourself living independently, or do you have to go to a long-term care facility? And as you can imagine, if you're confused most of the time or have some delay in recovery, you're not going to be able to participate in physical therapy fully, and you may not make that progress that you need to. And that delirium is a risk factor for prolonged impairment after surgery. Another surgical study, and this is more recent, is called Successful Aging After Elective Surgery, or SAGES. So they examined the association of delirium with an acute and long-term rate of cognitive decline. And just to make a note about why surgical population, especially elective surgical population, have been studied so intensely for delirium, is that actually when it's an elective surgery, you can actually do a good baseline assessment. Much less so with the medical population. It's really difficult to do a good baseline cognitive assessment. So in this case, they studied over 500 patients, 70 and over. They all had normal cognitive function as much as they could tell. And once again, they did a fairly in-depth neuropsychological testing at baseline. And they did baseline and daily delirium assessments during hospitalization, and then 1, 2, 6, and 12 months, and every 6 months up to 3 years. And they found that delirium incidence was 24%. These were patients who had major surgeries, but they were relatively a mixed population. The other one that I showed you before was a cardiac surgery population. So in this case, delirium rate was much lower. And what they found was that actually when you follow them, so compared to no delirium group, if you experience delirium during hospitalization, even though it was an elective surgery, there was a 2.8-fold increase in acceleration of cognitive decline, which they thought was attributed to delirium as well. So the next one is what's called the Brain ICU study. So continuing to really show association between delirium and long-term cognitive outcome. I call this my scary ICU study, because I think the findings are really, at least when I first read it, really shocking. So this was done at Vanderbilt, which I consider to be a premier ICU group. And they studied over 800 patients, both combined medical and surgical ICU. They had respiratory failure, cardiogenic shock, or septic shock. They did what's called IQ code that you might be familiar with, informant questionnaire, to determine that only about 6% had evidence of pre-existing cognitive impairment. Once again, this is a very difficult population to study because no one expects really to be in the intensive care unit, so they would not have had very in-depth neuropsychological testing at baseline. But as you know, ICU group has really high, one of the higher rates of delirium. And in this study, about 74% experienced delirium during hospital stay. And I would say about 70 to 75% is pretty much the norm across the globe in terms of ICU prevalence of delirium. So what they found was that after they were discharged from the hospital, at 3-month follow-up, even though only about 6% of the patient population was thought to have some form of cognitive impairment, 40% had cognitive scores that were comparable to moderate traumatic brain injury, and 26% had cognitive scores that were comparable to Alzheimer's disease. And at 12-month follow-up, very similar findings. So very persistent impairment at 1 year out from ICU discharge. And they also found that a longer duration of delirium, once again, was independently associated with worse global and executive function. So this is just a graphic representation of what we had just reviewed. So at the top, you can see a normal where we would expect the normal scores to be. And so they did an age stratification. And basically what you're seeing is that, basically many people score somewhere between what we would consider to be mild cognitive impairment, traumatic brain injury, and Alzheimer's disease. So you may say, well, these could have been older patients, so they might have had some underlying neurodegenerative disease. And so once they got very sick, it just maybe unmasked it or precipitated it. But what I can show you is that actually they saw this even in younger populations. So these were, a group of patients who were younger than 49 years of age. And so what you can see is that it's probably not just age, but something that happened in intensive care unit. There's a lot going on. Severe illness, medications, but also longer duration of delirium, if you've experienced it, was associated with worse outcomes. They have subsequently published studies on 2 to 3 year out outcomes. And what they found is that a lot of these people who were gainfully employed before something happened to them, acute illness and required intensive care unit hospitalization, many people could not go back to work, and probably mostly because of persistent executive dysfunction. So this is kind of the final slide in terms of delirium predicting dementia. So this is a UK study, and what's really unique is that I had mentioned that, we've been just mostly studying elective surgical population because we can do in-depth cognitive testing. So this is what's called DECIDE study done in UK. So they had this study group called Cognitive Function and Aging Study, and it was at 3 different sites in United Kingdom. And what they did was that they had signed up, a lot of older adults to have baseline cognitive assessments. And because of the socialized medicine, it was pretty predictable, well, they'll go to hospital. And so they studied this population that was that actually were hospitalized in one of the 2 designated hospitals. And what they did was that as soon as these patients who had underlying cognitive assessment, and this was done, I believe, between 2011 and 2013, over about 2,000 individuals, what they did was they were flagged as having had these baseline cognitive function tests and belonging to this group, and they actually had daily in-person delirium assessments by research assistants. And so they assessed number of delirium episodes, delirium severity, and once again, duration. And they assess for change in mini-mental state exams so they can compare to their baseline from several years ago and incident dementia 12 months later. And what they found was that an episode of delirium was associated with markedly increased risk of incident or new occurrence of dementia. And this is all adjusted value, even adjusted for frailty. And greater number of delirium episodes duration and severity was associated with worse cognitive outcomes. So if you had greater than one episode, so what they mean is that they would do daily assessments, they will have delirium, they might go away, and then they assess again, they might have another episode. And so really much greater odds ratio of developing dementia later on. And of course, we talked about duration. They dichotomized as greater than 5 days or 1 to 5 days of delirium. And if you experience more than 5 days of delirium, you had a much worse outcome. And similar findings for delirium severity. They use a delirium severity scale that was separate from just adjudicating from delirium or no delirium. And once again, that was associated with much worse outcome as well. So this is demonstrating the impact of delirium and associating with incident or new occurrence of dementia in medical population. So I want to kind of switch the gears a little bit. So we were talking about delirium as a risk factor for new occurrence of dementia. So I think, how about, dementia or underlying cognitive impairment as a risk factor for delirium? And I think many of us would say that if we saw a patient in emergency department and they carry diagnosis of dementia, well, of course, they're going to be at a high risk for delirium. So many studies showing that incidence of postoperative delirium and hip fracture definitely higher in patients with dementia. If you had no dementia history, it was 26% in hip fracture population. And if you had dementia history, 54%. Our latest study was what's called a STRIDE study, also in hip fracture study, where we had about 37% incident delirium as well. And elective joint replacement tends to be a little bit lower in incidence, about 7% incident delirium. So this is one of the systematic reviews that I did early in my career. And I just wanted to see, well, what are some of the preoperative risk factors that are important for predicting delirium after surgery in a hip fracture population? So these were just kind of the distilled variables that I looked at. I looked at many different variables, but cognitive impairment, age, institutionalization. So did the patient come from nursing home, from assisted living facility? Did they have underlying functional impairment by history? BMI, albumin, so low BMI and low albumin. And what we found was that basically these were all studies that showed that all these factors were significant in bivariate or univariate analysis. But when you adjusted for everything, what came out really positive in almost all the studies was underlying cognitive impairment. And many of these studies really didn't even do in-depth neuropsychological testing. It was as simple as doing an MMSE in the emergency department or asking just the very 4 simple questions like orientation and so on. So the next thing that I did was that I actually worked with a anesthesiologist, Dr. Fritz Sieber, to see, if we know that underlying dementia is associated with occurrence of delirium, how about those older adults who may not appear to have dementia, so they're kind of to be normal, but may have underlying neurodegenerative disease that's already starting? As you know, something like Alzheimer's disease is highly age associated. And so we do know by biomarker classification, patients who are now classified as having preclinical Alzheimer's disease or asymptomatic Alzheimer's disease, meaning carefully clinically define they're kind of to be normal, but by either amyloid PET scan or by cerebrospinal fluid quantification of amyloid and tau, they actually have amyloid burden or tau burden that's as much as somebody who has clinical Alzheimer's disease. So what I did was I piggybacked on his R01, where he was actually testing the hypothesis of light versus heavy sedation for outcome of postoperative delirium. And because all of these patients were undergoing spinal anesthesia, I basically, with the patient's consent, collected cerebrospinal fluid before they went under and had hip fracture repair. And so what we found was that basically, so this is the 70 folks were, we did clinical dementia rating, very careful history at baseline with the family members before they went to surgery to minimize the recall bias. And they were basically classified as completely normal and all the functions intact. And what we found was that regardless of the age group, it had a really high prevalence of amyloid positivity rate. So we had a cutoff score that we determined a priori that would be consistent with, having somebody with Alzheimer's disease biomarker level, and a great proportion of them, even though they were kind to be normal, actually had amyloid positivity. And I want to compare that to what we know about the general population. So this is a study from Jansen et al. Published in JAMA, where they basically collected a lot of biomarker data from observational studies. So once again, these were very well characterized, normal, cognitively normal individuals. And when you look at them, that in general population, amyloid positivity, if you're cognitively normal, would be about 23 to 32% in between 65 and 74, a little bit higher when you're getting older, and similarly 85 and above. And so I think what's really striking is that in hip fracture population, even in younger older adults, so 65 to 74, the rate or the prevalence of amyloid positivity rate is much greater in cognitively normal patient population. And so this is actually also congruent, just so that it's not just my study. I don't have data here. There's a group from actually Norway that have shown very similar findings in their cognitively normal population, that they also have a very, very high amyloid positivity rate. So what we might be observing is that actually patients, so this is just kind of showing the preclinical and MCI stages of Alzheimer's disease. So what might be ongoing is that the process of Alzheimer's disease, if you're talking about just amyloid accumulation, and I do want to acknowledge that I'm not saying that amyloidosis is necessarily causally associated with Alzheimer's disease. I know there are a lot of questions about that at this point, but we do know that at least for now, basically definitive diagnosis of Alzheimer's disease does require amyloid accumulation. And so what we know is that in preclinical stage, so these are very carefully characterized patients who are normal. They've already been having amyloid deposition for 10 to 20 to 30 years. And we know this because we have been studying them for about 20 years using imaging biomarkers and cerebrospinal fluid biomarkers and so on. So this is, slowly accumulating. And so this might be where we might be catching the patients who have hip fracture. So, and then definitely, with the MCI as well. So the idea is that, when we're seeing patients with hip fracture, I often get history like, oh, I just tripped on a cord that was on the floor, or it was the rug. These were patients who are falling repeatedly at home and finally breaking their hips. It was most likely to be centrally directed. So it wasn't just the rug. It wasn't just the cord. They actually had brain disease, one that was probably impacting their motor control. So we talk about patients who have, obviously any type of neurodegenerative disease, starting to have gait disorders, slow walking, and finally, example would be a Parkinson's, more of a shuffling gait, and Alzheimer's disease patients as well, and later on vascular dementia. So the point is that when you have brain disease, it starts impacting your motor control, and it's probably causing them to fall repeatedly and finally resulting in hip fracture. And so these are patients, even though when you have a hip fracture patient and they appear to be normal by history and by your exam, you should have a very, very high suspicion that there might be something going on in their brain already. And they are, even though they're cognitively normal, at higher risk for having delirium after surgery. Now, I want to kind of infuse the psychiatry aspect in this. So I thought, great. Now I have the key to all the answers. We're going to look at the biomarkers, and we're going to be able to predict patients, who would, are normal, but we'll have delirium. So I basically put the biomarkers in with all the other variables, and surprisingly, what actually came up at the top in adjusted model was actually the geriatric depression scale. So this is GDS-15. As a side note, this was not our primary outcome that we were studying. So we just had GDS in, I think, as just part of, having GDS, MMSE, and so on. We weren't really thinking that this will play a big part, but we had collected at a baseline and adjusted for age and all other things. Basically, it came out at the top. So, and also remained significant. So, total group, both combined patients who have dementia and no dementia, this and the MMSE were statistically significant. In no dementia group, which was still a large proportion of our patients, so 175, combining both CDR of 0 and 0.5, which is almost an MCI category, it also came out still positive. So overall, and in no dementia group, GDS 15 came out at the top and remained statistically significant. And in the no dementia group, age was also, significant. So we tried to look at this in a different way as well. So we use a different methodology. So we use what's called kappa tree. So this is kind of a baby version of machine learning. So if you think a machine learning method, you're really trying to digest millions and millions of data points. In this case, we did have N of 200 in our cohort, but it's very similar concept. So basically, we throw all the variables in and we let the machine basically decide, what comes out at the top. And machine learning, once again, pick GDS as the top. So if you had GDS 15 score greater than 2, that was really the branching point. And then, with the 2 branching out to MMSE as well. So, but really MMSE, and where actually the biomarkers did come in as third most significant, if you had low GDS score, relatively intact MMSE, and then it became somewhat significant. But the point is that even though we use a completely different methodology and let the machine do the picking, so to speak, it came out at the top. And these were all the variables that we put in. I mean, we basically threw in the whole entire kitchen sink. I think there were like 22 variables, but it still picked the GDS as the most important variable. So, what is it, I think GDS is telling us, and this is just my interpretation of what we saw, is that, we went in trying to quantify what's called amyloid and tau in cerebrospinal fluid, and they're very well validated biomarkers of Alzheimer's disease. But I think, we do understand now that older adults, so hip fracture population is, I would say average age of 82, 83, especially in our population. There's a lot of other things that go on, as you know, TDP-43, a lot of vessel disease, so vascular dementia and so on. And then if you're undergoing surgery, you're coming with trauma, so there's a lot of inflammation as well. And so the point is that trying to basically understand the outcome just based on 1 or 2 biomarkers may not really capture the entire story or the picture. So why is GDS coming up at top? I think what it might be detecting, especially in patients who do not have dementia, is non-cognitive symptom of underlying neurodegenerative process. So often, we think of, Alzheimer's dementia, so you have memory problems. So that would be more the cognitive problems. But we do know now that actually neuropsychiatric symptoms precede cognitive impairment. So complaints of memory loss or even like problems with neuropsychological testing by many years. And there's a study out where they've looked at the Alzheimer's Disease Research Center cohort and shown that patients who were normal, signed up as normal volunteers, participants at baseline, and they ended up having MCI due to Alzheimer's disease or Alzheimer's dementia. Many of them, over 50% of them, had the first symptoms or cognitive problems or the signs of Alzheimer's disease was actually depression, agitation, irritability, a lot of neuropsychiatric symptoms. So I think what we're capturing is a non-cognitive aspect of underlying dementia status. And so we call that sometimes the mild behavioral impairment or MBI. And now we also know, that people show up with basically, some functional impairment. There's a whole group up in Albert Einstein that studies MMI or mild motoric impairment, people who start having gait disorders before neuropsychiatric symptoms or memory disorders. So, but I think we're trying to understand, why is GDS, coming up at the top? And what it might be is that we're basically capturing all the underlying pathology that is manifesting as neuropsychiatric symptoms. And that's just my personal hypothesis on this. So once again, just kind of, reiterating exactly what I said, this is a data by Rush University, which I would consider to be one of the premier Alzheimer's disease research centers. And so as you know, they have the religious order studies where a lot of nuns and priests have signed up to be followed up longitudinally, as well as the Alzheimer's disease research center. And what they found was that these were patients or participants who were classified as having clinical Alzheimer's dementia or Alzheimer's disease by really experienced hands. And they went to autopsy. And when they went to autopsy, what they found was that when you're looking at oldest of old, and so these were mean age of 91, and these proportions are statistical proportions, they're not exactly the percentages that we can think of, but really patients who were classified as having Alzheimer's disease, the Alzheimer's disease pathology explained only about 41% of the clinical symptoms. About 30% were, really attributable by other non-AD neurodegenerative diseases, Lewy bodies, hippocampal sclerosis, TDP-43 pathology, and then of course about 30% vascular etiologies as well. So what I want to transition into a little bit is basically, well, what do we know about the pathophysiology of this? We talked about delirium as a stress test for the brain. This is, basically showing that, well, underlying brain disease and or multiple systematic diseases. I tend to be a little bit brain centric, but I'm a geriatrician. So, it's important to understand that obviously our brain is attached to the rest of our bodies. And so having hypertension, diabetes, and a lot of other comorbidities will also put you at a higher risk for delirium. And, also, understanding that it's not, once again, it's not just about the brain, but everything else. So many other things that actually, really insult, so to speak, the vulnerable brain, underlying vulnerable brain, and result in delirium. So one of the hypotheses of why this might happen is actually inflammation. So once again, this was like when actually Dr. Mark Antonio from Harvard published in 2012, we didn't really have too much evidence. We don't really have a lot of animal models of delirium. There's about 2 or 3 individuals who studied this in animal models, and probably because it's really hard to figure out inattentiveness in mouse models, like, what do mice look like when they're inattentive? So it's really hard to kind of recreate the human syndrome in mice, and that's been kind of a barrier. But this is what they're showing is that, you could have sepsis, you could have surgery, there's a peripheral inflammation, it's basically traveling. And we always think of, having the blood-brain barrier as a protective mechanism from outside insult. But we're talking about older adults. A lot of them have friable vessel diseases. And so, you have a lot of leaky, blood-brain barrier. And so you could have a lot of things that basically seep into, so to speak, to the brain. And then in turn, basically activates the microglial system. So that's I think of it as like the cleanup crew of the brain. So it's in trying to do good, it's trying to basically clean up what's gotten into the brain. It also basically spills out more inflammatory biomarkers, and that also contributes to greater damage. So the idea is that when you have a prolonged delirium, which could cause neuroinflammation, that it's causing neurodysfunction. And so if it's of short duration, maybe there's a chance of recovery. But if you have persistent, longer duration or higher severity of delirium, basically that perhaps it could basically cause permanent damage and cause neuronal degeneration and what we had talked about, dementia. So here's some biomarker studies that have come out recently. So this is the surgical population. And what they did was actually they quantified CRP. Everybody knows what CRP is. It's a very good biomarker for underlying inflammation. And basically they did what's called discovery. So they just threw everything in and said, well, let's just see what comes up positive. And CRP was one of the one of the positive ones. And then they basically did an ELISA study as a confirmatory study. And basically what they found was that at post-operative day 2, patients who experienced delirium did have higher levels of CRP compared to those who did not. And that was statistically significant. And that was actually true even before they went to surgery and then in PACU, post-anesthesia recovery unit as well. So, kind of showing that as a surrogate marker of CRP, using surrogate marker of inflammation, that inflammatory process might be at work when you're having delirium. This came out in 2020. This is a biomarker called neurofilament light. You might be aware of this. So NFL. Basically, it's a non-specific biomarker of neurodegeneration. Now, the reasoning why it's being widely used, even though it's very non-specific, is that you can quantify this in blood. And although you quantify much less than compared to cerebrospinal fluid, there's a very good correlation between CSF and blood. And that's not so true for many other biomarkers. So a lot of people are using this by just doing a blood draw to see how much damage has occurred in the brain. And this is basically intermediate filament that makes up the axons. So when there's a basically neuronal damage, it kind of spills out and you can detect this in the blood. And so what this is basically showing is that compared to baseline, before surgery, the change in marker of neurodegeneration is much greater in those who experience delirium. Once again, a surrogate biomarker showing that delirium is not a harmless condition, but that it could actually be causing underlying neuronal damage. And this is just kind of taking you through the different postoperative days. It also correlates with delirium severity. So we talked about how longer duration, worse severity, higher severity is bad for your brain. And what's called DRS or delirium rating scale. Basically what it's showing is that once again, when you look at the peak, how high the delirium severity was, the higher the delirium severity, the change in the neuronal damage marker, so NFL, is much greater compared to baseline, showing that duration and severity probably matters, as we had talked about. We have shown that in epidemiological studies and smaller primary data gathering methods, and now we're showing by biomarker that delirium is probably not a harmless condition. Now, we're talking about surgery and anesthesia, just to kind of go back, although this is not a delirium study per se. This is done by Dr. Liz Everett from Australia. And so what they did was they wanted to see, well, just by undergoing surgery and anesthesia, does that cause brain damage? Since we talked about so many of the surgical population. And actually, although they do not take into account delirium in this study, what they show is that just by having surgery and anesthesia, you can see it rise compared to baseline. So this is change from baseline, rise in neurofilament light, once again, showing that there's probably some brain damage ongoing that's persistent through 48 hours, so 2 days, and also tau protein, which is another marker of neurodegeneration. You can detect this often when somebody has stroke during surgery. And so it goes up at about hour 6, but it does come down around 24. Now, the forever ongoing debate has been, what is it, surgery or is it anesthesia that's causing the brain damage? And I'm sure you have seen, or if not, maybe some people have asked you, I'm about to undergo whatever type of surgery. Should I have this? I'm really afraid that it's going to do some brain damage. And so actually, this is a really interesting study, and I have no idea how they got this done, but it's called Tori's study. So basically, they actually found volunteers between ages of 40 and 80 who were healthy, and they volunteered to undergo anesthesia without having surgery. So they didn't need to have surgery. This is just for study purposes. And they were exposed to 2 hours of general anesthesia. And then they basically compared blood biomarkers of neuronal injury and inflammation before and 5 hours and after anesthesia. And basically what this is showing is that there's not much difference between baseline and after surgery. And so the conclusion they came to very carefully was that anesthesia alone did not provoke inflammation or neural injury, and that it was most likely the surgery that is causing neural damage. Now, full disclosure, this study was done by anesthesiologists. So, I think we'll just kind of have to, understand that this is a very small study, but I thought it was very interesting because often patients have fear of general anesthesia due to the fact that, that it might cause neural damage. And there's a lot of, animal model studies that have shown that it does so, but this is just a human study showing that, well, maybe the damage is not as bad as it, we thought it was. But once again, it's just one study. Okay, so I, almost wrapping up, but I just wanted to really definitely kind of go through with you about prevention and treatment. So we talked about how delirium is so important and could be so devastating to our patients. So, what can we do about this? Often what hospitals do is, okay, let's just do delirium screening. And if it's positive, okay, we'll do something about it. I see it as a kind of a reactive stance. So the delirium has already happened. The damage has already happened, and let's figure out what we're going to do. I really think we should be focusing more on prevention, because we know that about 30 to 40% of delirium is actually preventable. And it's very low-hanging fruit. Time and time again, studies have shown that non-pharmacological multi-component delirium prevention method trumps medications every time. We do not have a medication study that has shown clearly evidence-based that can prevent delirium. And that's not from lack of trying. Many studies have been done. We just recently wrapped up a Rameltion study that was negative. So, what does that consist of? So orienting patients, providing them with activities, fluid repletion. Often we find ourselves, looking at patients who, there's a cup of ice, with, a glass of water, far away, and the patient's just kind of languishing in the bed because no one's helping them. Early mobilization, we're so fearful to get patients off the bed because we're fearful that they're going to have a fall, and that's going to basically, leave a mark on our safety records. So we want to really talk about safe, active mobilization during hospitalization, feeding assistance, vision and hearing, sleep enhancement. I think sleep is very, very important. Infection prevention, pain management, so oxygenation, hypoxia protocol, and reducing psychoactive medications. And when you do this basically bundle, what they have shown time and time again, and this is from a systematic review, is that you can reduce delirium incidence by 44%. So that's actually preventing delirium, not just reacting once you find the case. So you might say, well, that looks like a lot of things that we have to do. And I think, you're right. But care for, older adults, very, very complex, very, very complex. And, here's a quote by H.L. Mencken. For every complex problem, there's a solution that is simple, neat, and wrong. So I know I myself always wanted the magic bullet to kind of prevent or, treat a disease. But in fact, it's a factorial condition syndrome of delirium. And so we're going to really need a multi-pronged approach to prevent it as well. So this is just kind of, once again, showing that association. And, treatment of delirium is very similar. Once again, non-pharmacological method is highly recommended. Studies have not shown that much, so it is helpful, but not the impact is not as great as using multi-component non-pharmacological methods for prevention of delirium. So I'm going to start to close this out with talking about antipsychotics for treatment of delirium. There's been a large scale systematic review, once again, showing that there's no difference between haloperidol versus placebo or second generation antipsychotics versus placebo in making an impact on delirium duration, sedation status, hospital length of stay, or mortality. They do not make a difference. Now, I am very empathetic. I mean, I myself attend on the wards, and I've been a resident and an intern and all that before. So when there's patients who are very agitated on the floor, we're often, left with, what are we going to do about it? And so sometimes, we can think of, well, at least when we use antipsychotics, it will sedate the patient and that will kind of take care of the problem until the next day and so on. So we actually did look at sedation status, meaning did it make patients calmer or more drowsy, or did it do something by looking at randomized controlled trials and the adverse events or side effects that were noted in those studies. And in terms of when it came to sedation status, there was no difference between antipsychotics and placebo. So I'm not even really sure that it does that. The problem with using antipsychotics for these is that there's a persistent use of antipsychotics. Doctors, including myself, are very good at prescribing medications. I don't think we do as good a job of de-prescribing or taking the medications away when it's no longer necessary. And so what we find is that 1 in 5 patients were discharged from the hospital with antipsychotics if they received antipsychotics in the intensive care unit. So the point is, it just kind of gets left on, oh, maybe, it's keeping Mrs. Smith, a little bit calmer. And, we certainly want her to make it to the rehab center. So we'll just leave it on. And the rehab center, I don't know what she was on it for, maybe this is what she needs. So it kind of gets carried on. Certainly the patients, most of them don't know why they're taking, what they're prescribed. So it never gets, revisited. So there's a persistent use. And we do know that there's a, black box warning associated with these medications. Right. So treatment of delirium at end of life, palliative care, hospice, delirium is a very common finding. And often, I find that a lot of aggressive measures are used, especially antipsychotics. It's almost like a bundle. that gets put on when these things are put on. Once again, non-pharmacological methods are more effective and important. And here's one study that was published in JAMA Internal Medicine by Mira Agar. She's also an Australian. So they study basically antipsychotic use for hospice, palliative care settings. And they basically randomized patients to Haldol versus placebo and risperidone versus placebo. And Haldol and risperidone, compared to placebo, they both had worse delirium symptoms. Patients who took antipsychotics had actually worse delirium symptoms. They had longer delirium duration. And if you were on the Haldol group, they had higher mortality compared to placebo. But I think this is another demonstration that it's probably not doing what it's supposed to be doing or what we had hoped for it to do. COVID-19 and delirium. So delirium is a very common presentation. This is like a 7ED study where they showed that 28% had delirium at presentation and 37% of patients had delirium and no other typical COVID-19 symptoms. They didn't have shortness of breath, fever. They just came to the emergency department with delirium. But what it's shown is that now many people are interested in long COVID or the brain fog symptoms, and we're studying that at Hopkins as well. What it shows is that at least in the short-term duration, this was, really published. We don't really know too much about this, because of it's only been about a year and a half to 2 years in the pandemic. Basically, what this shows is that basically, if you look at long COVID symptoms, if you had delirium during hospitalization, it probably was one of the more impactful factor in terms of having persistent cognitive dysfunction outside of the hospital once they were discharged. So in summary, so most common form of delirium is often missed, hypoactive delirium. Unless we do active delirium screening, we will continue to miss 75% of patients who are experiencing delirium. Delirium can delay cognitive recovery and is associated with longer-term cognitive impairment. We talked about how delirium duration and severity are very important. And I don't know if there are many trainees on this Zoom call today, but this is one thing that, I would really like to emphasize is that often when we, go to delirium lectures, we learn all about the bad things it can cause. So, we do 2-week rotations, 3-week rotations, we get a warm handoff from our colleagues and we show up and, oh, the patient's already delirious. There's nothing that we can do. Actually, there's so much that we can do for them. If we can just look at those medications again, if we can revisit whether they're infected, if we can revisit a lot of other things that are happening with the patients, we can reduce their delirium severity and we can reduce their delirium duration. And I hope that that's really a take-home message is that do not give up on our patients, because I think that although most of these patients will probably never meet again in our lives, but you can really help them because I showed you today how impactful having worse delirium severity and duration can be for individual patients in terms of their cognitive dysfunction. And underlying neurodegenerative disease is a risk factor for delirium, both known and unknown. And biomarkers are coming into use and maybe really more useful in understanding pathophysiology of delirium. And I touched upon briefly in COVID-19 and delirium as well and its long-term impact. So thank you very much. And I would love to take questions at this point.
Dr. O, that was fantastic. I don't know if Dr. Moreno is still on or not.
Yeah, I'm here, but yeah, but please go.
That's okay. All right, we'll take it from here.
We'll open up for questions.
Okay.
I guess we prefer them in the chat.
We have lots of questions in the chat, Dr. O. That was fantastic, by the way.
Thank you.
I have lots of questions myself, but in all fairness, we should probably take them in order in the chat. So, Chris, do you want?
I'm having problems getting my chat to come up.
Sure.
Could you start on the chat? Absolutely. I cannot see them.
Absolutely. I think there was a question that came in earlier in your talk, and I think you answered it. Does anesthesia or surgery cause increased inflammation in the brain?
Yes, we do think so. And we have, it's not, I think obviously it's been very difficult to study in human population. But there's a lot of animal models that have shown that, yes, inflammation may be kind of the common pathway. We had talked about multiple, insults to the brain. It's a multifactorial, syndrome, really. It's not a disease, but that inflammation might be one of the common pathways that it's basically causing damage.
Okay, thank you. I wonder if we could take the slides down so we can see each other a little
Sure,
more
of course, yes.
readily and ask the questions. So the next question in the chat is from Eileen Weiner. Does dementia itself increase risk of delirium even when there is no underlying medical cause? Do you see more of a mixed picture of delirium dementia as dementia progresses?
Yeah, definitely. So I think, I'm just construing that the question is whether if you had cognitive impairment, but you're relatively healthy, does that put you at a risk for, a higher risk for delirium?
Right.
Definitely. But I think, just once again, I'm a geriatrician. So, I think it's important to understand is that, if you have a lot of patients with comorbidities, most likely that they also have, some underlying neurodegenerative condition. And I think it's important to understand that, cognitive decline is a natural phenomenon. It's age associated as well. So as we get older, I think the line of, what's disease and what's normal aging, it kind of gets blurred. So if you're seeing older patients and they have some cognitive impairment, that might not be, dementia as we would think of like in 60-year-olds, but could be a, part of the, normal aging process as well. But it's much more mixed and, less clear in terms of like a focal etiology than younger, older adults.
Okay, thank you. Can I squeeze a question in here? I'm just wondering, should we be automatically screening then with the GDS, given the relationship that you mentioned earlier in your talk? Should that just be part of a regular CL consult or office visit?
Yeah, no, I think it depends. So there's one other study, it's from Northern Ireland, where they have looked at mixed populations, so elective and hip fracture, so elective hip replacement and traumatic hip fracture population, and they did not show association between GDS and post-operative delirium. What we're hoping to do is, moving forward prospectively, now that we have this data, actually do both GDS as well as do the model behavioral impairment, so MBI checklist, to see, if we can kind of refine the questions. So I think it's, we did publish this study, and there was the editorial accompanying it saying, look, depression as a, risk factor for delirium, and it's true. But I do want to tell you that when we look at the GDS, actually, I have slides on this. Okay, if I may just do share screen for just one time. So, I had talked about how, neuropsychiatric symptoms we often find in, cognitively normal patient population who eventually go on to have, Alzheimer's disease and so on. And this is from, our, oops, I went too far here. Okay, so this was a distribution. Do you see the histogram? So, yeah, yes. So, yeah. So basically, so once again, we did have psychiatrists, but we weren't really looking for depression. So we're just looking at the screen and, screening tool and using the cutoff. Most people were actually kind of in this background noise, not really meeting GDS criteria, although the GDS actually as a continuous variable correlated superbly with basically Alzheimer's disease biomarkers. So I'm not sure that it's a depression per se, and I'm kind of afraid to say this like in this group because I'm probably not very good at describing depression. But the point is that if you look at like, here's the item score that we looked at. So the most common item on GDS that came up as positive or flagged was, do you often get bored? Yes. Describing more, I think, apathy. And I see this a lot in patients who have cognitive impairment or are starting to have some symptoms, as in they lose interest because they really can't do the things that they used to do before. So I'm wondering, as an aggregate, it's a depression scale, that we happen to be using, but item score may be showing that it's about these different features of what happens when somebody's starting to develop cognitive impairment that we're picking up with GDS. And then another thing is that the most surprising item was, remember, these are patients who just broke their hip and like laying on gurney in the emergency department. And the one that flags on GDS is, do you think it is wonderful to be alive now? So, only 14% said no. So meaning like, 86% thought, yes, it was wonderful to be alive now, and they just broke their hip. So those kind of like, it's somewhat non-scientific, but just really trying to understand what the next steps are. I did not, think that it was depression per se. Or, it's not ready for prime time, but I would be happy to listen to your feedback as well, like what you think of it, everybody.
Okay. Anybody have a comment on that? All right. Well, that's fascinating. So the next question in the chat is from Dr. Lewis Cohen. What about surgery with spinal anesthesia instead of general anesthesia?
Yes. So if I were to get surgery, I would get spinal anesthesia. But here's the important thing, is that what people don't understand is that you also get a bolus of like propofol, so you still get something through the vein, because you don't want to be awake while somebody's chiseling away at your hip. So basically that was the really question about the R01 that I piggybacked my career development award on. What Dr. Sieber, at the anesthesiologist at our institution, was finding out was that even though the patients were having spinal anesthesia, they were getting propofol to a point where basically it was almost like a general anesthesia. Yeah. So that's what you have to be aware of. So one study, our study, showed that there was no difference between light versus heavy sedation by controlling propofol. There's another study that just came out saying that it does. So I do think that, so personally, if you had to go get, surgery now, and if it's like orthopedic surgery, I would recommend spinal anesthesia. And I would recommend that you find an anesthesiologist who would do light sedation for you. I think that would be better for your brain.
Great. Got it. Thank you.
Get the A team.
Yeah, right. Exactly. Here's another question sort of related from Steve Davis. Any trials of preoperative anti-inflammatory treatments in at-risk folks, at-risk people?
Yeah, so I think that's a fantastic idea. I've thought about it, but if you think about things that are readily available as an anti-inflammatory agent, usually those are kind of contraindicated, before surgery.
Right.
So before, and then, what I find with a lot of older adults is that, let's just say NSAIDs. I'm very careful about using NSAIDs in older adults because of the kidney issue. And many people who come in with like hip fracture, they might have been on the floor for a long time and robbed the myolysis and then, kidney damages. So I think it's a fantastic idea if we can have an anti-inflammatory agent that has less adverse effect. But I think that's a fantastic idea.
Interesting. Okay. Another interesting question we have from Dr. Eric Goldwasser. Thank you for the talk. Would screening prior to surgeries for status of blood-brain barrier leakage, i.e. IgG or albumin indices, help inform risk for development of post-operative delirium?
No, because we have just studied this in our data set and we did not see difference. And if you look at other people's studies, it's fairly equivocal, meaning some studies have shown that the Q albumin, as like the index that you had talked about, does make a difference in terms of predicting delirium, and similar number of studies have shown that it doesn't. So, okay. So it's right now, it's not a practical tool, I would say. Mm-hmm.
Got it. Okay. Next question. Thanks for the excellent presentation. I was wondering if you have looked at circulating RNA and DNA in CSF and blood samples collecting at the same time to identify early biomarkers.
No, we have not looked at circulating RNAs. I'm not sure what this is pertaining to, like what biomarkers specifically, but at least from my laboratory experience, RNAs are fairly readily degraded. So they're actually really hard to collect, or if you know, it's like there are a lot of biomarkers that you'll see in the literature as like positive. Like one example would be like IL-1 beta that persistently, consistently comes up as positive biomarker in mouse models. Bottom line is that in human subjects where you're collecting blood and it just kind of sits on somebody's table for 2 hours, usually they're degraded by the time it hits your ELISA plate. So those kind of barriers. So I'm not familiar using circulating RNA as a biomarker for delirium, but I'm not sure how stable they are as well. For practical use.
Can I jump in for a second? There was one interesting question that I threw with, and this from Dr. Goldwasser, and it's about would screening prior to surgeries for the status of the blood-brain barrier, like the integrity.
Chris, we already asked that one.
Yeah.
Oh, we did? Where did I not hear that? Oh my gosh, somebody texted me. All right, I'll shut up. Sorry about that.
We're way bit by you. Okay, so lots of fascinating questions. Cindy Schaefer, Dr. Schaefer asks, can dehydration alone trigger delirium within MCI dementia patients?
Absolutely, absolutely. So, I think one important thing to kind of understand is that, the picture that I showed you about the underlying vulnerability and risk of delirium. So if you have a young, healthy patient, like they have to be dehydrated in the ICU on some, like Epidrip, and all those things to become delirious because they have a really, good brain to start with, let's say a 30-year-old. In older population who have MCI and, dementia, you don't have to do much. You can just be like one pill, a little bit of dehydration, to basically push them over the edge, so to speak. And I think, I want to emphasize that often, because we're so ingrained in how we practice in the hospital that, when we find patients, older patients with, dehydration, that we just have to kind of bolus them. And then what invariably happens is they go into heart failure because we just gave a bolus of 0.9 normal saline. I want to just really, encourage people to kind of think about like hospital-wide changes where we have, either a bedside, technician or somebody who can actually help the patient drink water by mouth, which is a little bit of a slower method, but will keep them hydrated. So just kind of, I think, I'm kind of going off on a tangent, I'm sorry, but because I'm a geriatrician, this is something that I've been really thinking about. So yes, the answer is yes, dehydration alone can cause it, but I think we can really prevent dehydration, especially when they're in the hospital. It's just that we can get reimbursed for 0.9 normal saline, but Medicare won't pay for extra personnel who would help them by sitting by their bedside and helping them drink. That's the difference.
I just have to say that this issue of getting the elderly to drink is a huge challenge. I have a 91-year-old mother who has had a couple bouts of this, but you could have a glass of water sitting there, and she's not in the hospital, she's at home, and you can't get her to drink it. Like, she just can't get her to drink it. It's a fascinating problem. And
may I share tips and tricks?
Absolutely.
Yes. So in older population, especially those who have cognitive impairment, when you put a big thing of like, big Gulf size, from 7-Eleven and just put them by their bedside and ask them to drink it, it's completely overwhelming. So what I ask my caregivers to do is, like, if they have a shot glass from Niagara Falls, just get that and pour water in and give it to the patient and just say, Mom, this is all you have to drink. And Mom drinks it and she forgets that she had, a little shot glass full of water. So you just fill it back up and you put it back in again. And then voila, they drank in a whole thing of, big Gulf size of water. So that's how I encourage, and that has more success. Another thing is that you can actually use rice-based oral rehydration packet. So what it is basically, especially in patients who have diarrhea. So basically, this was actually developed for patients who have cholera, like in, Bangladesh and so on. So basically what they found is that when you have a lot of diarrhea, basically a lot of the sodium water basically transporter gets shut down, except it preserves glucose water transporter. So what happens is when you give this rice base, it's called Ceralite. You can probably use Pedialyte. There's a lot of other formulations that come out. Basically, glucose acts like an IV needle. So when you put the packet in and you have the patient drink it, it actually really promotes hydration much faster. It's like giving them basically IV fluid without, putting IV access in. So those are kind of 2 tips and tricks that I have.
I love it. I'm going to try it out.
The shot glass method.
Shot glass, right.
Yeah.
I don't know if I have Niagara Falls, but I'll find
Okay.
it.
Well.
Okay. Let's see. We have a little bit more time left. We have the next question from Sophia Kozak. Thank you for the great talk. As a current second-year psychiatric resident, 2 questions. When ruling out delirium, as we often have to do, should we always be getting inflammatory markers like CRP, like you mentioned, or to build a case? And the second question is regarding delirium recommendations. It seems like there's mounting evidence against using antipsychotics. Do you think we're headed towards stopping making antipsychotic recommendations?
So
there's 2 questions there.
Right. Yeah. So one is you do not need to get CRP to make the case. Delirium is a clinical diagnosis. So you can use, basically DSM criteria or like use a 4AT or confusion assessment method to make a case. But one thing that I would tell you is there's something called subsyndromal delirium. It's like high blood pressure. Like, does somebody not have hypertension if their systolic blood pressure is 139, but they do if they have 140? Same thing with delirium. So even if you use a screening tool, there might be cases where you kind of meet the criteria, but not exactly. And those patients might have subsyndromal delirium, and they might actually go on to have full-blown delirium later. And they also are, known to have really poor outcomes. So here's what I would tell you is that you are clinicians, so you have to make clinical judgment, and that's good enough. You do not need to get a CRP, because a lot of things that you'll be doing for the patient would be non-pharmacological interventions, de-prescribing, working out for infections, things that we would be doing as, clinical providers anyway. So that's what I would say.
If you don't mind, can I jump in and
Yes,
make
yes,
a
yes.
comment? Yeah, I'm Dr. Dodi. I'm one of the geriatric psychiatrists. 2 things. Thank you. Very complex subject. Thank you for trying to cover most of it. I have 2 comments. Every time I have residents and students, because I worked as a consultation psychiatrist in a general hospital where there is a medical residency program. There is always patient is behaving, exposing themselves, urinating, transferred to psychiatry. I used to tell the medical residents, delirium is nothing but acute brain failure. You don't want me to transfer a patient with acute heart failure, acute brain failure. Brain is as important, if not more important. So every time I get an opportunity, I try to keep bringing it up. I also know delirium can lead to dementia if you don't handle it properly, and mortality rate is very high if you don't correct the electrolyte fluid and electrolyte balance. In several hospitals I worked, we never used to transfer a patient with delirium to psychiatry. But I'm proud to say this is one thing we do differently at University of Maryland. We do take patients with delirium, even though residents may complain it is too much work. I think it keeps us on our toes. We have consultants available at any given time. My question to you, Dr. O, is it is just not only just terminology, but also important for the research statistics. When do you start, when somebody has prolonged delirium, when do you stop calling it delirium and saying this is dementia? This applies to the statistics when you do the research study. Saying somebody has delirium 3 months. I have the residents asking, why are we not calling subclinical delirium? Why am I calling dementia? So I just want to raise the question.
Sure. So I will answer your question first, and I do want to go back to the second part of the other question as well. So, delirium and dementia can coexist. Certainly, I would not make a new diagnosis of dementia while the patient's in the hospital. Dementia, I would say, as you know, is an outpatient diagnosis, and they by definition, like they can't be delirious. So it has to be kind of, has to resolve. When you have patients with severe dementia, and this is we as a field really struggled with this. It's, let's say somebody who has MMSE of 11. It's really hard to determine like what is delirium and what's dementia, but I would say that this is just personal opinion. I find their attention to be an important and useful factor for me because I see a lot of patients with dementia through the memory clinic. And often, even though patients have, dementia that's a little bit more advanced, I find that even if they're very tangential and not really answering my questions, they can be attentive, but like not really directly answering my questions. Patients with delirium, inattention is one of the cardinal symptoms. So they would just either kind of like fall asleep while you're talking to them, not necessarily because you're really boring, but because, there's like an active brain disease going on. So I would use that as kind of a, distinction, but I do empathize that, that's a very difficult problem because in advanced dementia, it's hard to distinguish from delirium at times. I want to go back to the antipsychotic, use. So the issue is that, once again, I think I did mention to you that I'm very empathetic about this issue. I do find that I can avoid antipsychotics by using patient safety attendants. We used to call them sitters, but by just really having somebody nearby, just really redirecting them and making sure like they don't fall out of bed. But often, person power is in short supply and we can't find them. So, I have used them time to time, but really rarely, but really because, I use the patient safety attendant. So yes, we should not be using antipsychotics. There's no evidence there. However, I think, a lot of things happen. So this is not delirium, but more into dementia and using antipsychotics. As soon as Medicare kind of clamped down and said, you can't use this, the use kind of went down, actually even before that. But what has happened is people just use something else like Depakote, like gabapentinoids. So when you look at huge Medicare claims data, that is what's happening. And there's now people are realizing that older adults on Neurontin, like benzodiazepines, as they also impact the brain. It's just that it doesn't flag in the system as an unsafe institution. So I think we have to be really aware that we can kind of come, really hard down on one class of medications. I think, just things need to be used, judiciously and really minimize side effect, but also being aware that, they call it multimodal, pain regimen in order to, like decrease narcotics. Other things that are being used, same thing for, psychiatric disorders as well as behavioral problems of dementia. So just kind of being mindful that, are we using things that are just as bad, perhaps, but doesn't get clamped down on. So that's what we're doing. So I just want to kind of talk to you about that.
I'm
Great.
sorry, but I don't want to take
No,
over the whole discussion. Very quickly, we have patients who are waiting for placement. Hypoactive delirium versus dementia. You don't want to send somebody to nursing home with a diagnosis of delirium. So what I'm trying to say is, even though it is a complex question, we have to decide, because some of the statistics you presented saying 1 year delirium, I would call them dementia. I wouldn't call them delirium after some time. I don't want to take over more and have a discussion, so I'm going to stop it now.
So we do have 2 more questions I'd like to get to before we run completely out of time. Dr. Catherine Harrison-Rastelli asked, last few slides, in the study where the patients who received antipsychotics had worse severity of delirium, do you think antipsychotics worsened or prolonged the delirium? Or rather, it was more severely delirious patient who got antipsychotics because they were so symptomatic, team felt compelled to try to treat symptoms rather than defer antipsychotic.
Yes, all the data that I presented were randomized controlled trials. So they were just basically randomly assigned. So I think that kind of answers, could it be that, it's basically, association by just a degree, exactly, like you used more because they were badly off in the beginning, but they were randomized controlled trial results. I think once again, it's important to, emphasize that those 2 were all the studies that presented, they tend to be a little bit smaller, although the big data that I showed you were from, systematic review and meta-analysis.
Okay. And the last question in the chat from Steve Davis, the economic costs of delirium are quite significant. Do you know if CMS, Medicare, has considered paying for some sort of delirium triggered bundle of services to improve time to recovery? Interesting.
Yeah, not that I know of. As you know, medicine is highly politicized. So, there's a delirium, as I call them, and hopefully you do as well. And then, actually, a lot of people call them encephalopathy, and sometimes we're describing the same things but differently, and that gets reimbursed differently by Medicare. So right now, there's no, nothing has been done in terms of, really looking at delirium. What almost happened, and AGS, American Geriatric Society, stepped in and prevented, is that just like, traumatic falls in the hospital, where Medicare came down and said, if somebody falls in the hospital and they have a very severe consequence, not just any fall, I think that I want to make that distinction, their hospitalization does not get reimbursed, which is kind of like made a lot of hospitals basically immobilize our patients, and actually, I think, cause great harm, in my opinion. Same thing with delirium. It almost happened that my understanding is that delirium, if you develop delirium in the hospital, it was going to be a non-reimbursable condition. And AGS really, American Geriatric Society, really fought back, because if you think about it, if that becomes that, we're going to stop looking for delirium, right? Because we're going to be punished. So, I think it's medicine, economics, politics, can't separate them. But I think at the end of the day, we just have to be, I guess, our patient's advocate. But, those kind of things are happening. So it almost went the other way, not like, giving rewards for treating delirium.
Right.
It's going to become almost like a punishable offense that your patient developed delirium, when in fact it's so highly prevalent.
That's great. That's a good point. Good point. So that completes all the questions we have in the chat. Go ahead, Chris.
Guys, one last question, because I just want to follow up on two things. One, which pays more, delirium or encephalopathy?
Encephalopathy.
Oh, interesting. Number two, just to get back on the antipsychotic thing, because I think all of us have been in a situation where you have someone who's so agitated, and maybe they're in ICU and they're pulling at things. It's hard to say there's no role here. Is there any possibility, like when it's a randomized trial, okay, we can look at causation, but was severity excluded up front? Like if you were so out of control? Because I do wonder at some point, we're struggling with this now. We had someone on a medicine service who was so delirious, they broke a limb, they suffered a fracture. And so now we're using medicines on our unit to treat it. We can allow people to walk around, but it's like, so I don't know where the line is.
Yes, I mean, once again, I mentioned that I'm very empathetic. When I was a postdoctoral fellow, I had a geriatrics attending who told me for every prescription of benzodiazepine, I was going to spend 1 year in purgatory. Like I didn't prescribe benzodiazepine for a long time, but I come to realize that, sometimes in some patients, for example, patients who have a lot of behavioral problems, sleep disorders, and have cardiac issues, I might use a little bit of benzodiazepine. So I think there are always exceptions. And I think that's where clinical acumen comes in. We have this evidence, and they're not necessarily always, applicable to all of your patients. So, but I think, what I hope to kind of demonstrate to you is that like antipsychotics and those things that we know have, black box warnings should not be the first line of treatment. And that there are other options that we can do, that prevention is better than reacting to delirium. But this is not to say be judgy and say, oh, you gave 1 dose of antipsychotics, you're a bad provider. That is not the point of, the message. Yes. So sometimes we do, and, as, behavior, I do a lot of, behavioral management of dementia. I do use antipsychotics. And I know it's not good for them at times. And
to make it concrete to the patient level, that same doctor who made the purgatory comment started a patient of mine who had spent years getting off of benzos back on one. So it is patient specific.
Oh, yes.
Okay, sometimes I think we should give the benzodiazepine to the treatment team on the other service.
Yeah, it's actually treating the doctor.
Yeah, right.
It makes me feel better.
Well, this has been fantastic, Dr. O. I really appreciate the time and your patience in taking all of our questions. It has been a true delight, and it's so nice to know that you're not that far away from us.
Great. Thank you so much for your time. Bye-bye.